Most people who call us don't begin with a clinical question. They begin with the one underneath it. They say things like, I don't know if this is bad enough, or I feel like I should be able to handle all this on my own. Or quietly, almost apologetically, I just don't know what I'm supposed to do next. And that uncertainty, that not knowing, is one of the most important things we listen for. Because in our experience, the people who are genuinely unsure whether they need this level of care are often the ones who need it the most. The illness itself has a way of convincing people that their suffering isn't serious enough to warrant intensive care. So let's talk honestly about what residential care actually is, who it's genuinely designed for, and how we think about that question at Florida Oasis. Because you deserve a clear answer, not a sales pitch. When you call us, whether you're calling about yourself or someone you love, our first job is not to fill a bed. Our first job is to listen carefully enough to understand what's actually happening. We're listening for the shape of suffering, not just its intensity, but its texture, how it moves through a person's day, what it does to their relationships, what it's already cost them. There are specific things we're paying close attention to. We're listening for what the in-between sessions look like. Outpatient therapy, even good outpatient therapy, gives someone 1 hour a week of structured support. We really want to know what the other 167 hours look like. Are you using your tools? Or are you white-knuckling through each day just trying to survive until the next appointment? Is the environment you return to after each session the same environment that's making you sick? If the answer to those questions is yes, that tells us something important. What we're really listening for is functional collapse. I mean, there's a clinical difference between someone who is struggling and someone who's no longer able to maintain the basic structure of their life. We ask things like, are you getting out of bed? Are you eating? Are you able to show up for work, for your children, for the basic responsibilities that anchor a life? When those things have started to fall away, not because of laziness or weakness, but because the illness has consumed the energy required to sustain them, that's a significant clinical signal. We listen for safety. We ask directly without judgment about suicidal thoughts, self-harm, and any behaviors that have emerged as ways of managing unbearable pain, including alcohol or medication use that's become a survival strategy rather than a choice. We're not asking to alarm anyone. We're asking because safety is the foundation everything else is built on, and we need to understand it clearly. We're listening for treatment history. How long has this been going on? What's already been tried? How many therapists? How many medication adjustments? How many programs? When someone is genuinely engaged with lower levels of care, not avoided them, but truly tried them, and the symptoms have not responded, that history matters enormously in our clinical thinking. We're also listening for environment. This is one of the most underappreciated factors in level of care decisions. A person can have excellent coping skills and still be unable to use them if the environment they return to every day is actively dysregulating their nervous system. Chronic stress, relational conflict, unsafe living situations, or simply the weight of daily responsibilities that leave no room for recovery, these are not personal failures. They're clinical realities that a residential setting is specifically designed to address. We use a structured, individualized framework to think about what qualifies a person for a residential level of care. And there are specific presentations that consistently indicate that residential treatment is the clinically appropriate choice rather than a step down or intensive outpatient option. When depression is so heavy that a person can't reliably get out of bed, prepare a meal, or engage in the basic tasks of living, that's not a motivation problem. That's a severity problem. When anxiety has become so pervasive that a person can't leave their home, can't sleep, they can't function in any consistent way, weekly therapy, even excellent weekly therapy, doesn't have the structural capacity to meet that level of need. The same is true for trauma responses that are so activated that a person can't feel safe anywhere, or mood instability that's cycling faster than outpatient appointments can track. We're also looking for failed outpatient treatment, genuine engaged failure. This is one of the clearest indicators we see. When someone has worked sincerely with multiple therapists, tried multiple medication regimens, and participated in lower levels of care without achieving meaningful stabilization, that's not evidence that they're unfixable. It's evidence that the level of care has not yet matched the level of need. Residential treatment exists precisely for this population. Another thing we're looking for is the inability to use the skills in the home environment. Because there's a profound difference between knowing a coping skill and being able to access it when it's needed the most. When someone can articulate exactly what they should do during a panic attack, but can't do it at 2 a.m. in their own bedroom, that gap is not a knowledge problem. It's an environment and nervous system problem. Residential care closes that gap by placing skilled support in the same space where the suffering actually happens.